So in preparing this workshop, I really wanted to think about, is MI really apropos to violence? And the one benefit is I actually have two studies that I've been working on for years of bullying. So we've been using MI for bullying in two studies in Australia now for, I think, 8 years, and we all flew down there last November to visit our study. And we've written a paper that's still in press, so unfortunately I couldn't give it to you yet, but we wrote the conceptual issues as, is MI really work the same for violence behavior? So I want to share with you some thoughts, but more important, I want to get your feedback. Because on some level, when you think about what MI has been used for, let's lop off the substance use part of your study. That's a no-brainer, because that's really the roots of MI. MI started as a substance use, but let's talk about the violence part. Initially, it might seem very remote from where MI started, because MI started as a way to help addictions, and people with addictions have what we used to call denial, and they're resistant, and they have to overcome cravings, and they have to worry about withdrawal. So at first blush, maybe this MI thing doesn't apply to violence. And there are differences. Now, I want to make sure you don't interpret these as reasons MI wouldn't work. These are simply differences. So let's go through this a little bit. Well, it turns out that MI does not have to be used for addiction. If you remember the slide I shared with you of cholesterol and blood pressure, those are not addictions. The key thing is, MI works when people have to exert behavior to control an impulse. It's, in the addiction world, it's an impulse to smoke it, inject it, snort it, drink it. In the chronic disease world, it's an impulse to eat the French fry. It's an impulse to stay on your couch and watch TV. It's an impulse to not take your medication. But fundamentally, what MI is about is impulse control. And MI only works when things are volitional. So we don't usually use MI in completely coercive situations. So if you're in a situation where you do it or you go to jail, MI is of marginal benefit there, perhaps. So in general, our view is violence really maps onto this. Violence is controlling an impulse. It's not the same impulse we typically think about with addiction and with chronic disease prevention and management, but it's an impulse. So what's that impulse that you think we're talking about? I think it's obvious, but I'd like you guys to verbalize it, particularly the Flint team. What is some of the impulses we're talking about with your kids or young adults? Yeah. It's an impulse to protect yourself. It's an impulse to lash out. It's an impulse to assert or dominate through, yeah, that's an impulse. And like any other impulse, it is generally volitional. Yes, there's complicated issues. We'll get there. It is related to their substance use. It is related to other personality issues. No doubt, it's complicated, but it fundamentally is an impulse control. So in that way, in the most important way, I think MI maps very easily onto aggressive behaviors. Number two, MI really helps when there's motivational issues. If someone's completely motivated, we don't really need MI. If someone comes in and says, I've thought about it, it's my choice, it's meaningful, and I feel I can do it. We call those the three criteria for clean motivation. They probably don't need MI. Now, what percent of people, when they enroll in a study, have that? It's close to zero. So don't worry, you're not going to bump into too many kids who come to you and say, I've really thought about it, it's going to be hard, but I have the skills and I'm completely motivated. Those people are rare. So the key thing is, I think you're going to find lots of resistance, ambivalence, and insufficient motivation. Another reason why MI maps very cleanly onto aggressive behaviors. Like other things, there are triggers. It can be a certain person triggers them. It could be substance use or certain states associated with substance use trigger them, just like with food and other addictions. So I think it also meets that criteria that the plan may be, in part, how to address triggers. Okay? You don't go to certain parties, you don't go out with certain friends, you don't get high before you go to the parties, things like that. You don't bring your gun or your knife, things like that. And finally, it turns out, in the world I live in, which is the disease management world of large healthcare systems, they have come to Jesus in the last 5 years. It used to be that they only looked at high utilizing patients. So you understand they want to save money. Obese patients, smokers, and people who go to the ED a lot are really expensive. So they target the high utes, as they call them. In the last 5 years, the sophisticated clients I have, and I'll say Aetna is one and Kaiser's another, they said, well, it turns out it's depression and hopelessness that co-varies so much with these that we have to add behavioral health to disease management. So it used to be that disease management, which is generally phone counselors calling people about your meds and your weight and your exercise, were solely focused on the symptoms. And behavioral health was this sort of other thing that you bought as an add-on, as a sort of, well, it's a nice thing to add on to your program if you can afford it. But now they combine them and say, well, we can't think that these are separate phenomena from physical health. So increasingly, hopefully, our healthcare system understands that these issues are really integral to the behavioral issues. And I think that is really classically related to what you're dealing with, that these kids are coming in with lots of behavioral and psychological problems, and we have to think broader than simply the aggression and the substance use we can't ignore these things. However, there are some clear differences. Partner violence almost always involves another human being. So there's a dyadic or social contextual aspect. It doesn't mean MI is not relevant, but it means your discussion generally involves how do you interact with someone as part of the fundamental treatment plan. Number two, we heard earlier about, well, violence is what we do. This is protective. There's so much aggression in my neighborhood. If I don't stand up for myself, I'll be perceived as weak, and it's actually safer for me to go and get involved than it is to be passive. So we understand there's cultural and contextual factors here. What's very interesting is almost all of the other behaviors that MI has been used for, not quite all, but close, the major competitor is hedonic pleasure. That fundamentally we are battling the id, if you remember from Freud. We are battling the instinct for self-gratification. Violence partially works through that pathway, but it's not fundamentally reinforced by the pleasure of the act. Now, the drug use that is associated with it is, but the act itself is reinforced by things other than pleasure. But it turns out most of MI's work has been trying to handle hedonic impulses. So in that way, it's quite different. And that impulse includes aggression, not just the impulse to have pleasure. It is probably not considered an addictive behavior. Of course, you can map any behavior as addictive if you use a very loose definition, but by most expert definition, aggression is not an addictive behavior. And the other, I think, final thing I came up with in our paper and in thinking about your workshop is that it has a very complicated relationship to substance use. For some kids, substance use causes this, and substance use creates the state at which they're vulnerable to violence. But conversely, if you've been the victim, or even if you're just the perpetrator, sometimes it is the consequence of violence. You do it to numb, or you like to do them together. And so it has a very complicated bidirectional relationship. And it's not a bad thing. It doesn't mean MI doesn't work. It's just different. So this is my and some of my colleagues' take on how aggression maps differently and how it maps similarly to the classic behaviors. I would like to spend a few minutes getting your thoughts on this. So which of these, you might disagree with them, or anything else you want to add or modify about MI from what you know after our first hour and a half, 2 hours together, plays out similarly or differently for the Safer Teens project. There is an argument that ultimately it has a hedonic component. And that is, after people exhibit or exert violence, they feel cathartic. What is that word? Purged. They feel that their aggression, at least temporarily, it may refill in 10 minutes or an hour or a week, but short term, there is an argument that aggressive responses actually are slightly hedonic, meaning that the person feels almost a sense of calm after. Now, it's not the primary benefit that people refer to, but this has been reported by a few interesting studies. That the person sort of feels like they got out their frustration, they were able to lash out, and if for at least a short term until it fills up again, they feel cathartic. They feel like they purged. So I'm not going to go into here a couple other comments from this. How else do you think violence, partner violence, is similar and different than other behaviors that typically MI has been used for? Well, I'll tell you, it's similar in one other very important way. I've already mentioned it, but I want to go back to it at least one more time. In your experience, for those of you who have had clinical interactions around violence, partner violence in particular, what are the reasons people stop? What are the drivers of that change? And then I want to make a point with that. So what do you find have been the predictors or the things people voice as to why they decided they would change? Mm-hmm. Okay? So she mentioned two very positive ones: being a better role model and to feel more accountable. And then a more sort of pressurizing, which is you want to avoid negative consequences. And we're all for, we'll take controlling motivation over no motivation. So if the only thing you have is avoiding consequences, we will take it, because it can last up to a year or two. It's not as if it only lasts for 5 minutes. So we will certainly take a controlled motivation versus none. Who else has a comment about an insight? Those are three very good ones of why these young adults are going to, or from your clinical experience, have changed. And then I want to see if we can make a unifying point from this. So if they were shot at, even if they didn't have a severe injury, that could be quite traumatic. So this is one of the reasons I believe your intervention is very promising, is because you are in the middle of a transformational event if you leverage it properly. I think you could really take advantage of. Now, we wouldn't use the Dr. Phil sort of tone. Do you want to be here again? Do you want to keep seeing me? Those are not the ways we think the epiphany will occur. But if you back off a little bit and sort of say, you know, what's this experience been like for you? And the person hopefully won't say, this has been great, I love the orange juice here, I think the food here is much better than UofM. I don't think you're going to get that. I think most people, it's an aversive event. So what your job is, if you want to think about it, is have them voice to you the trauma, or even if it's not that extreme because they ended up with a 2-stitch cut, but regardless, that this wasn't fun, or this, I got lucky this time, or I don't like being around you people. That's fine too. I don't like this damn place. I don't like getting billed. I hate that. So what I'm trying to say is here, it's not on this, and I hope we came at it and we kind of did on our own, is that the reason people change violence and aggression are really the same reasons people change anything else. It's a difficult behavior because it's contextually bound, it's reinforcing, there's reasons it's positive, it gives people status, it's cathartic. But fundamentally, they're going to change primarily because it's not just the consequence, it's part of it, that they can avoid negative consequences, is that it doesn't feel right to them. And they would much rather be living without going to the ER. They would much rather be living without worrying about the police in their life. And most people further will say, and we'll get into this later today, most people would rather have more peaceful relationships with their partner. Very few people say this is the ideal state. If you were to ask someone involved in partner violence, is this the ideal state for your relationship? Is this what you had imagined when you were defining your ideal romantic relationship? Very few people will say yes, it involved lots of hitting and lots of visits to the ED. So in a more positive frame, we want to think about their positive definition of a good relationship. And the discrepancy we want them to see is this is not that. So we'll talk about it later today, but one of the primary ways you want to take advantage of how MOI works is what would be a good relationship for you? How would you define a healthy, productive relationship? And then have them compare that to what they are now. And we really think that could be a strong source of epiphany or discrepancy or disruption, however you want to define it. All right? Yeah? Yeah? All right, we're almost done with theory, believe it or not.
Does it matter how long they've been engaging in the behavior? Say it was a first
Yeah. No, it's a great question. So
a first episode of violence or repetitive behavior?
I was actually trying to look at that. So I have to ask you guys, I only know from the world I'm most familiar with, which is the addiction world. So for smoking, I know this is a very indirect answer, then I'll ask the people who actually do violence. For smoking, number of prior quit attempts does not predict the next quit attempt very well. Pack years, which is how long you've been smoking and how heavily, slightly predict it, but it's in part because it predicts how addicted you are. So the question is a very good one. And if anyone here, Pat or Rebecca, know, is there any data from your studies whether or not the duration of prior partner violence is a predictor of future any more than my last event is? Because in addiction, there is a little bit of data about that, but I don't model this as an addictive behavior, but maybe it does map that way.
So I'll answer, and then I'll let Maureen answer as well. I think for the dating violence studies that in the how this plays into dating violence here, we found, and I think it's because people think it's a little more relevant, but those who noted that they've had when we asked them how many episodes of dating violence or aggression or victimization they've had, if those episodes have been more than a couple, like 2 or 3, I think we found, those folks were more likely to have change than if it was their first episode of partner violence, and they'd only had one and we were talking to them. But I don't know that the same is true of youth violence. I think that may be specific to the partner violence component. And in fact, for the youth violence one, actually I'll answer this and then I'll turn it over for this. So for partner violence, I think we found that, although we also found, so it may work slightly better for that group, but also we found for the group that hadn't even personally experienced this yet, but it was more prevention when we did it as part of Project Sync, even if they hadn't yet had partner violence or dating aggression necessarily, that this type of style could impact their change and their future behavior going forward. So I think the sum is you don't necessarily have to have been either engaged in it a very long time for this style to matter. The converse question, I think, is almost more difficult though, which is if you've been engaged a very long time and are very entrenched, is it harder to change then? I don't know that we exactly have that answer now, but Maureen, do you want to comment on that?
We don't have enough data to answer that question as sort of the bottom line. That some people think there's a sweet spot that these kind of interventions work best, meaning that they may not work for people with severe, but there's no data to support that. And in fact, our data, when we looked at severe violence, which isn't the pushing, slapping, shoving, this is the punching, the group fighting, the weapon-related violence, kicking, this is the more serious violence in terms of likelihood of causing injury. We did see reductions in severe violence, but we have very few gang-involved kids in these studies. In fact, and you know this clinically, I'm guessing, but we only see like about 5% of kids are actually involved in what you would think of as a gang. So this is more just sort of normative fighting.
So our experience is the duration and the intensity of behavior is not as much a predictor as the resistance. So what we have found is MI works better with more resistant clients. So there is this paradoxical relief we want you to feel. So when you have a kid who comes in and says, I'm definitely not going to stop, you have no idea what it's like, that actually for us is a pretty good indicator that we can do some benefit here. Because the argument we have found is that these people have lots of energy devoted to thinking about it. They're actually quite aware that they have a problem. It's just currently they're devoting all the energy to defending it. But we can flip that energy. Where we can't help is what we call the amotivated patient. And I'm going to jump ahead because I think it's a really good way to introduce self-determination theory. So self-determination theory, which we're going to describe right now, talks about 3 levels of motivation. And although this is going to be mumbo-jumbo psych theory, it's the last part of our introduction. We're almost ready for skills, so hang in there. It is actually quite informative, and it tells us why MI works. And their continuum is, it says there's 3 levels of motivation. The strongest level of motivation is intrinsic motivation. The intermediate level is extrinsic, and that's where we actually work. MI works here. There's one type of patient we really can't help, and it's called amotivated. And the amotivated patient doesn't even have the energy to muster up resistance. Their response is, I can't even think about it. I'm overwhelmed with so much. My life is such shit. I can't even think about this. So the one patient we have little to offer is the person who says, I can't even talk about this. I can't even think about it. But that is balanced by the good news that if someone is really resistant, we actually have really good outcomes. So the person who has lots of energy that's currently just devoted to defending it is someone who we have found can be flipped. So let me talk a little bit about SDT because I think it's a really good way to answer, I think, your great question. So SDT has its own website. Similarly to MI, has about 3,000 publications. And its effects are equally impressive. The only difference is SDT, self-determination theory, is not an intervention approach. MI is an intervention approach. I sent you guys an article, and hopefully, if you haven't had a chance to read it, the theme of the article is MI was a practice looking for a theory. SDT was a theory looking for a practice, and we have recently mated them. So we have recently combined MI and SDT, and using SDT as the theoretical explanation for why MI works, and for the SDT people, we've said, here's MI, here's a clinical application of your principles. And when we say we mated them, we literally did. So we flew in, this is true, Miller and Rolnick, and DC and Ryan to Belgium. And a few of us who said, you guys need to mate. So it's like pandas at the Washington, D.C. You don't realize it, but all of us really want you to mate. And we literally locked them in a room with some coffee and other refreshments and said, could you come out with an agreement that this is a good marriage? And it worked pretty well. And they came out and they literally wrote an article that's in a journal that we sent you one of the articles from, and said, well, we decided we don't really want to get married, but we all agreed we'd go out on a second date. And ultimately, we have written a series of articles that say SDT is a wonderful explanation for MI, and MI is a wonderful clinical application of your principles. The two grandparents of the model, DC Ryan and Millen Rolnick, they had, I think, their own reasons for not going all the way, so to speak. But for those of us who weren't as invested, most of us who do MI think it's a wonderful marriage, and I'll explain why. So SDT, DC and Ryan are the two progenitors. They're at the University of Rochester, upstate New York, have shown across the entire realm of cultures. They've done it, I think, in over 30 countries, that we try to predict human performance. And their research started as predicting who does well in school and who does well in the workplace. So fundamentally, it was sort of organizational psychology. Since then, it's been used to explain health behavior, and there's already multiple meta-analyses, but their original research was about explaining academic performance and worksite performance. They found that when these three human needs are met, people do well. So think about it in a school or a worksite. If you, as a teacher or you as a supervisor, support your student or employee's autonomy, that's a really strong predictor they're going to do well. Number two, if you help them feel that they are competent, that they have these islands of competence, even if they're a D student in math, but they're an A student in art, if you can help them celebrate their competence, it tends to have a spillover effect, and they start to feel better about their other areas. And finally, if you can make work in school socially meaningful, if you can help them feel less isolated, alone, they do better. Well, it turns out that these three human needs that have explained very nicely, students who do well and workers who do well, actually explain which patients change their behavior. So it turns out that patients who feel autonomous, patients who have competence or efficacy, and patients who have a social network that is supportive end up quitting smoking, losing weight, exercising, taking their meds, and again, the meta-analysis that have looked at the multiple studies almost all show the exact same thing. These three needs predict health behavior change. So for a second, where does this apply to partner violence? So in your study, what's going to be the autonomy that you would be focusing on with these kids and young adults? What do we mean by autonomy and volition from the perspective of this project? Think about it. So where are we going to try to inculcate autonomy into your messaging and your counseling? It manifests with things like, I'm not here to push you. I can't force you. This is completely up to you. I cannot make you stop this. I want you to know that. This is your decision. So one of the key strategic, practical ways that you inculcate autonomy is to make sure you communicate that it is up to you, not me. I cannot force, coerce, or in any way twist your arm. How do we support their competence? How do we take advantage of competence in this intervention? We have to make them feel they have the ability to do so. So what competence, be it a cognitive skill or a behavioral skill, might you be talking about with these young folks that would give them competence? What would be something that would let them walk out of the ED feeling I'm able to do this?
Many times I try to draw a connection to something that I know they've achieved in the past. I tell them, hey, look, you've done this. You obviously have these skills, the ability, and you've had success in the past, so.
Great. So self-affirmation of a prior accomplishment or other skill is one of the classic ways to build confidence. So we will specifically tomorrow walk you through an exercise where you show them a card, and the card has a series of things that you could have achieved. I've overcome a disease, I've overcome a difficult childhood, I've done well at sports, whatever it is, and we try to borrow competence, just like the clamps metaphor. We want to clamp it on to their competence. Any other ways that we could establish competence? I want you to think about how particular skills or preparing them for high-risk situations might help their competence. How might that play out? What can you do with them clinically that might improve their sense that I can do this? How can you prepare them for a particular high-risk situation? So what would be a high-risk situation for one of these kids?
I mean, could you maybe talk about problem solving?
Yeah, and I'm going to be more concrete. This kid in front of you has a particular peer group. When they get together, they do drugs and they have a long, almost like gangs, have a long history of violence. What would you do to help increase the competence or try and give them skills to keep that down?
Role play?
Hmm?
Yeah, what can you do instead of being involved in the violence, like she said, role play?
Okay, so it can help them handle that situation. They can do any of the normal strategies. They could avoid that situation. They can go in with coping skills or alternative ways to handle the challenge. Okay, for some people, maybe a very simple behavioral strategy of don't bring your weapon, although your kids, I understand, may not be the number one way they're defending themselves, but it's in the repertoire. So the key thing is, and we'll talk about it, is you increase competence by giving them alternate coping strategies and by also showing them they're stronger than they think or they have other islands of competence. SDT has divided motivation into two classes, autonomous and controlled. Looking at these two, which is the one that you think lasts longer and which is the one that has a relatively short half-life? Sandra has nominated autonomous as lasting longer. Does anyone else want to endorse her opinion? Why does this last longer and why does this have a half-life? Remember that study with the alcoholics in Northern California? The column of relapse was controlled motivation. The column of sustained abstinence was autonomous motivation. So what is, in your words, what is it about this that has a much stickier, longer term prediction of success than this, which has a relatively short half-life of motivation?
Choice.
Okay, so it's yours, so you own it versus it's external. What else? Inherent value. So the kid, hopefully in your study, really sees for their own life this is better for them. Not because you told them, but they have come to the conclusion. This is where you have to respect silence and you have to have faith that some of this will occur outside the session. They have come to the epiphany that this is not in my best interest. And when someone has arrived at it from that perspective, it seems to have a really long, enduring effect. I don't want to get stuck on the mumbo jumbo. I don't particularly find the terminology intuitive, but I do want to talk about this thing that they call introjected. Introjected motivation is a fancy word for saying people initially start their behavior change process with guilt, shame, and fear. And that's okay. That is an okay place to start. But perhaps the number one message that MI and SDT teach us is that ultimately what your job is as an interventionist is this. They come in with this. They come in with guilt, shame, pressure. In your case, I think there's probably definitely a tone of maybe fear. Your job is to move them from here to here. Your job is to purify their motivation and to be much more inherent. They want to be saying, I really want to do this, not just I'm scared of this happening again. So consequence avoidance is an okay starting point, but it's not where we want to end. So here's what we define, and I mentioned these earlier, as the three components of quality motivation. This is where we would like your participants to be after your MI session. If you have done your job, they would be basically verbalizing, this is my decision, it's important to me, and I feel I can do it. Those are the three components of quality motivation. Conversely, dirty tar sands motivation has these components. So again, to understand MI, you try and move them from this, which is what they often will bring to the party, and get them towards, you know what, I've really thought about it. I'm not doing it just because my parents threatened me or because you scared me. I'm doing it because I want to, it's meaningful, and I think I have the ability to do so. So where they're moving them from here to here. Does anyone have any questions about self-determination theory and how it's relevant? What is the role, do you think, of autonomy in adolescents and young adults? How important is autonomy to them?
Huge.
So one of the reasons I really like the age group you're working with is you can really exploit autonomy. That is such a driving force in their development that focusing on volition and reinforcing that it's up to them and telling them you're going to find your own pathway should be very powerful for this age group. Okay?
Don't you find though sometimes that could work against you with this new YOLO theory? And they're just so impulsive. And I love the commercial where these three boys are and they go up to the horse and the first one gets kicked and the two look at each other. Then the second one goes out and gets kicked. And the third one looks at both of them and just walks away. So it kind of reinforces that you don't have to live once. You don't have to have this horrible experience to actually use your brain to know that's not what I want to do.
Mm-hmm.
So I find it very difficult sometimes to work with the kids because they go, let me make my own mistakes.
Mm-hmm.
So trying to flip them into that type of thinking instead of
Yeah. So
all
we're
these I gotta experience everything.
and it may be for some kids change won't happen until they've tasted it, so to speak. But we have a cute little thing we'll talk about tomorrow called an amplified negative reflection. It's the MI version of is this working for you, but it's a little bit more sophisticated. So I'll just tell it to you now, but we'll practice it tomorrow at some length. And it's basically rolling with resistance on steroids. So you take whatever they say, and this is only used when the person is really stuck and is really voicing these what seem to be almost self-destructive statements.
And that's what we see in the ER. I'm not sure if you agree, but these kids are in total crisis, and we
Yeah.
see the kids who have a lot of risk factors and in terrible crisis, not only for themselves but their families.
Mm-hmm. Good. So when we hit what we call someone who's in the yes but spiral of death, that there's nothing you could tell them that they wouldn't reject, the technique in its general form says back to them, so at this point, you're really happy with how it's going. So at this point, you don't see any benefit whatsoever if you were to try and change this. Can't be. It's not meant to be sarcastic. So the Dr. Phil stuff has that tone of sarcasm and got you. This is with a much greater sense of what we call innocent bewilderment. It's sort of like, I'm confused here. It almost sounds like you don't see any benefit at all, or you almost sound like you're happy with how things are. So it's a very powerful technique, but we also refer to it as our nuclear weapon because it can blow up in your face, and when it does, rapport can really suffer. So it is something that we'll talk about tomorrow. It's not the first thing you say. It's a last fail-safe thing, but it can be very powerful if you feel you have someone who's just in this massive yes but adolescent phase, and it's quite common.
The clinical staff who might have heard about other programs that happen in different places in the country, it might be important to know that some of the programs that have been tried in different places around the country don't work and kind of do cause harm. So kind of the classic one that 20 years ago when we started we were hearing a lot about was well-meaning clinicians and nurses and doctors taking kids through the ED and showing them what could happen and sort of that scared straight model, and showing them that the tubes would be awful and the trauma would be awful, and all the literature on that basically shows it increases their violence. It doesn't work. So it's well-meaning and well-intentioned. Unfortunately, it doesn't have the outcomes that we want. The same thing with the kind of infamous, I lived through the DARE era of drug prevention. DARE increased drug use among children. So for those of you who aren't as familiar with kind of all the health behavior change literature in the clinical world, so that kind of approach is much different than what we're talking about today.
Fundamentally, those are scared straight messages that it's worse than you think and you better buckle down because you're not going to get away with this. Those are amongst the most damaging messages we know of. A colleague of mine at Penn published a really powerful set of papers a few years ago when they looked at the Office of National Drug Control Policy, ONDCP, which was the Nancy Reagan agency, but it's still alive, and it's usually been headed by a military general, not a behavior change person. That for the first 12 years, it was led by a military person. The people writing the messages were military. So one of the worst campaigns ever was marijuana. It's worse than we thought. And I don't know if any of you took the health comm course. I forgot, maybe none of you did. So we show all the ads. So the ads for marijuana are, my brother died from a car accident, he's catatonic and he can't even get out of bed, he has no brain cells left, it's going to get you arrested, it's illegal, it's a felony, and that's the entire campaign, was massive fear messages, and literally the tagline was, marijuana worse than we thought. And so the Center of Health Communications at Penn looked at attitudes towards drug use amongst people who were exposed to those messages and those who weren't. The hope of ONDCP that people who were exposed to those messages would not smoke weed. The effect of the intervention by our geniuses in DC was the exact opposite. Kids who saw those ads were far more likely to smoke weed than kids who didn't. It had what they call a boomerang effect. And there's a couple of theories why it didn't work. One theory is it normalized something that actually was not that common. It normalized heavy marijuana use by saying everyone's doing it, and the meta message is when kids hear something as normative, they're more attracted to it. But the bigger explanation is the messages were so inaccurate that they lost their credibility to the point that the individual audience member was able to completely reject the message without any effort. You made it so easy for the kid to not respond because they all said, that's not my experience. None of them know anyone who's heavily addicted. Kids in school very rarely are daily pot smokers. And very few kids die of an overdose each year. In some years, they've actually said it's 0 if you take out accidents. So the message was so inaccurate that it created something called reactance. So I want to talk about reactance for a second. I've already mentioned it, but it's a very interesting thing. So first of all, reactance is a little bit different than resistance. Resistance is the baggage the patient brings into you. Reactance is the additional weight you put into their bags when you use controlling motivation. So when you masturbate and shit all over your patients, you are putting additional weight into their psychological baggage. You are magnifying their resistance with something we call reactance. Reactance is a initially very simple phenomena, and the theorists argue this. Human beings are just like self-determination theory. These theories were developed in complete independence, but the reactance theorists said human beings across the planet are predisposed to wanting to feel free. If you threaten that freedom, they will react. Think about it politically as Tiananmen Square or the Arab Spring. But what's interesting about their theory is they actually mapped out clinically how does reactance manifest. And it manifests in something called restoration. So people restore their freedom to controlling messages and controlling environments in one of two ways. The first way is sort of obvious. They do the behavior, okay? So if you tell people you can't protest, that's a really good motive to make them protest. In terms of behavior change, think about the Northern California study. So when your wife and your doctor tell you better not drink, what happens is it creates an impulse for the person to now go out and drink. One of the best proofs of this is when they look at people's brain in fMRI machines, so you're watching their brain in real time, and you show them cigarette warnings that are fear-based. The part of the brain that is triggered is the craving part of the brain. It increases craving. It's not even a conscious reaction. But once the person is told to stop something they are not ready to stop, their natural impulse is to feel a craving to do the opposite. So it's one of the reasons we have to be extra careful not to use controlling messages. The other effect of restoration is indirect. And what happens is, and this is what we're more worried about in your study, if you migrate into the old school of counseling and you use fear messages and you use Dr. Phil strategies and you use it's worse than you think or you better buckle down, soldier, two things happen that are invisible to you as the therapist. And the two things are they will attack the message and they'll attack the messenger. And what happens is they discount both in their head and they'll say things, what the hell does this white chick know about living in Flint? Or what the hell does this black woman know who's got that Mercedes outside? They will attack you in their head and they will attack your message. And what makes indirect restoration so insidious is that you can't see it going on. Outward, they're like this, sure. So it's very hard to detect the psychological process of reactance. But we know we create it when we try to use controlled motivation. Think about yourself for a second. Think about when your spouse or your boss threatened you last. Not threatened you like with violence, but said, you better do this or I'm going to be pissed. Can anyone volunteer the last time someone in their life made a threat? Again, not a physical threat, but you better do this, you better stop shopping, or you better cook dinner or something. Who would like to volunteer when someone in their life gave them a better statement? You better do this. Anyone?
My reaction is typically, okay, I need an escape plan to figure out plan B.
Right. And that avoidance behavior, which is what we call, it's a form of negative reinforcement. You can just avoid the situation, is you avoid the situation clinically by saying, I don't have to listen to her. She's not credible. And that's what they do when you give them controlled motivation. And it's not exactly anything new. It goes back almost 400 years. If you want to boil down MI to its simple syrup, it's getting the kid in front of you to tell you why this isn't working for them and what it would feel like if they got control of this. That's really what you're trying to do clinically. It is in some ways that simple. The classic textbook definition of MI is this. And I'm going to show it to you, not necessarily because I care about you memorizing it or you know it, but it has two very important points to it. It's very recent. This was not the definition 5 years ago. The new definition, I don't know if you have this slide, is that MI is particularly interested in reinforcing change. I mentioned this earlier, that the research on change talk has really shaped how MI is trained. We really want you to listen and elicit change talk. We'll spend almost all of tomorrow showing you how to do that, how to filter out those little fragments of commitment. Secondly, it's getting the person to explore their own arguments for change. So that is us attending to change and trying to elicit from the person their personal reasons. This is the definition we have used, and I still think it holds. It's a combination of spirit and technique. Spirit and technique. For those of you who are not aware, MI started in roughly 83 or 84 is the first paper. For the first 10 years or so, almost every publication was around an addictive behavior. So it started out with alcohol, particularly treating alcoholics on the work site, where there were sort of these coercive programs that if you don't quit, you lose your job. And the results of those were so abysmal that Miller said, I just needed something different. I had no theoretical understanding of what I was doing. I was just trying to do something other than that. So to him, MI was just not that. And of course, it's become much more theoretically based, but that's not its roots. Its roots were much more necessity is the mother of invention. In the mid-90s, a small group of us said, why not try for chronic disease behaviors? So we started out with smoking, which is a nice crossover because it's both sort of an addiction and a chronic disease behavior. And then very rapidly, by the late 90s, it had started to be applied to obesity, physical activity, diet, adherence. And since then, there's not one major disease where there hasn't been a clinical trial. So if you name a behavior, a chronic disease behavior or another form of risk behavior, and even primary and secondary prevention, screening, and immunization, MI has been used. So at this point, it's seeped into almost all the nooks and crannies of both public health and medicine. So one very clear implication of everything we've talked about is MI teaches us to move from a push tone to a pull tone. We do a lot of e-health interventions at the U. When we write messages in general, we write our messages with this tone versus this tone. So I hope you can see the subtle difference. Here we're hoping the person finds their way. We don't overpromise, this is what you should do, this is the answer for you. We almost never would say that in MI. We're saying there's many pathways. Everyone has their own reasons. Everyone has their own strategy. My job is just to help you find one. If you can find even two, that's great. But this is the type of counseling that creates reactance. This is the type of messaging that is perceived as controlling. It does not support autonomy, whereas this type of messaging allows the person to find their own way. Here you're the rudder, here you're steering the boat. And maybe we don't need anything from science, we just need Dr. Seuss. So if you don't know Green Eggs and Ham, the story was Sam kept pressuring him to try, you will love them, you will love them. And eventually he said, back off, stop telling people. One of the worst ways to persuade someone is to tell them, this is the greatest movie ever, or this is the best restaurant ever, or you're going to go out with this guy, you're going to fall in love with him, he's amazing. That is a terrible marketing strategy. You know why? It almost always fails. Has anyone ever liked a restaurant as much as the person who recommended, who said this is the greatest restaurant, or liked a movie or a book? It's very rare. And the reason is, if you set the standard of, this is amazing, this is wonderful, you're going to love this guy, the person is no longer any room for self-discovery. The fun is you finding that restaurant, or you finding that movie. You've taken that away. And now the person's natural reaction is to reject it. So too with advice. If you tell someone, this is what's going to work for you, they no longer can discover that restaurant on their own. And now you've just put them in a position to reject it and tell you why it's not going to work for them. We refer to that as behavioral skeet shooting. You float up an idea, they shoot it down with one of their yes but bullets. And they have many more yes but bullets than you do advice. You will lose that battle. So one of the number one rules we want you to get away from is floating individual pieces of advice. Because by and large, until someone is fully motivated, advice does not stick, it is simply shot down. So we're going to discourage language like this, masturbating and shooting. We're not going to try and inspire or exhort or to say, you're stronger than you think. We don't cheerlead. We'll talk about alternate ways to try and inspire besides the traditional. So before we start our skills, and we're just about there are times not to do MI. So the ED is actually not your part of it, but the ED is the classic environment when we say MI may not be applicable. So let's say a patient has been wheeled in with a gunshot wound, and they're about to lose consciousness because they're bleeding out. You could, as a physician or the nurse, the triage nurse, say, sir, you do have a gunshot wound. It hit a blood vessel. You probably have another 2 minutes of consciousness. I think we have a chance to save your life. However, I also notice that you're a smoker. And it's really up to you. So obviously there are times when autonomy and choice don't matter. What is completely appropriate for you to be 100% on the steering wheel. An interesting debate that I don't think we'll have time to go into today, but I at least want to plant it in your head, is where is the boundary of that? Where it is completely appropriate for you to take total control and autonomy is no longer relevant. So we have a little grid where we say, here, if the person is in a very acute condition and they're not in a psychologic state to contribute to the conversation, it doesn't have to be lack of consciousness, it can just be incredible arousal. They're just so anxious and scared that they can't participate in shared decision making. So this is the quadrant for which we would say MI just doesn't make any sense. On the other end, there's an obvious place where it makes complete sense. We're talking about chronic diseases and they're in an emotional state where they can contribute. I'll just give you one gray area to think about, and then just maybe if you're interested we can talk about it later, or certainly just amongst yourselves. A very good example is a project we have in the University of Michigan Cancer Center, where we're training docs how to do shared decision making with women who have breast cancer. When women have a basic form of breast cancer and it's caught early enough, there's no survival benefit of lumpectomy versus mastectomy. They have the same outcome. They have a little different process in terms of chemo and radiation and hospitalization, but they have the same mortality benefit. Normally, we ask our docs to do shared decision making and do a form of MI so that the woman's values and goals are incorporated into the preference-sensitive decision. But if she is just diagnosed and she is in a state of shock, okay, she's in a low state of decision making, and it feels very acute, even in this case, we probably map it about here. It's not a gunshot to the head, but emotionally she is not in a state to contribute. There, if the patient says, if I was your mother, what would you do? we normally train the docs to deflect that. We normally train them to say, well, I'm happy to tell you, but we have found it's generally better for you to be a part of the decision. If the woman was just diagnosed and she's completely freaked out, that maps here, and we tell the docs, it is fine in that case to say, well, if you were my mother, I would say this. We just add one kicker to it, and that is, but I want you to know, if you change your mind over the next 2 weeks, I'm completely okay with it, and it will have zero impact on your survival. So you sort of put in a little kicker on the end to say, by the way, we can always change our mind. But at that point, it will be more comforting. It will probably calm the person down more for someone to decide. Another thing that would be sort of probably here is you're just diagnosed with a chronic disease. It's not going to kill you, but you just found out you have high cholesterol. And the doc says there are 17 drugs we could use. And you're like, I do not want to read about 17 drugs. Just make a recommendation, and I'll start with that drug, and we can change it. That's another case, because of the state the person is in, that it may not pay to use an MI style. So my point is, although MI is completely appropriate in your study because it's chronic behaviors, okay? And if you were there to treat their gunshot or their knife wound, maybe you would not be doing MI for the initial, I know it's not the same team, but if you were treating both, you would probably be in a more directive style for an hour or two. But when they come out and do your study, you switch. So clearly your study is in the realm where MI matters, but I want you to know you don't always do MI with every patient under every circumstance.